guys. Dr. Mark Vaughan doing an Ask the Doctor on a Friday afternoon. I'll turn the camera around and see who's joining us. We already have people, Ralph and a couple other people. Well, welcome to the Ask Dr. Vaughan. Buttermilk 1995, thanks for joining us. We're glad to have you be a part of this also. And we can go ahead, once people get here, we get done greeting everybody, we can get some things going. Tothmo, thanks for joining us. We're glad to have you here also. And maybe we'll have some good discussion here. Big Red, you're here. Great. You always have good things. Gen 3, thanks for joining us. We're glad to have you here. Oh, hearts are starting already. We haven't even gotten started doing things, so this is awesome. Oh, and we have an excellent question. What is vasovagal response? Okay, there's two parts to that word, vaso and vagal. Vagal refers to the vagus nerve, the 10th cranial nerve? Yeah, 10th cranial nerve. Hey, Big Red. And Vegan 05, thanks for joining us. The 10th cranial nerve cranial nerves refer to the 12 cranial nerves that come directly from the brain. They don't even go into the spinal cord first. Happy Friday to you too, Princess Mish. So you have 12 of them, starting with the olfactory nerve and going all the way down. And the 10th one's this one called vagus, and it goes a long ways. Most of them are just in the head, cranial meaning the head. But this one goes all the way down. Hey, how you doing? All the way down into the chest, and actually goes into the abdominal cavity. And all along the way, nerves are coming. Oh, and Shannon Grosskreutz, thank you for joining us. And Sturts1, K Sturts1, thanks. So this nerve, yes, hi Shannon. So this nerve, when it fires, can affect a lot, it can affect a lot of parts of the body. Now, one of the things it can affect is large blood vessels, and it can cause them to dilate. It also, oh, Princess Mish, somebody asked about the vaso-vagal response. So I'm talking about the cranial nerve, the vagus nerve, one of the 12 cranial nerves. It comes through the middle of the chest and into the abdomen, hitting different things along the way, and it also innervates the heart, it innervates the stomach, and is involved in autonomic nervous activities, autonomic or automatic functions that your nervous system takes care of by itself. There's two parts to it. There's the sympathetic and parasympathetic, sympathetic being the fight or flight type of state of your body's existence, and then the other one being the rest or digest. Obviously it stimulates acid production in the stomach. That's why when some people have really bad acid production, in particular before medicines like Nexium and Prilosec were around, a procedure that was done commonly would be to cut the vagus nerve as it innervated the stomach to decrease acid production. Well, it can also do, excuse me, it can also do some other things. Vasovagal refers to its effect on blood vessels that will dilate them. It also will stimulate the heart and slow it. It'll also stimulate the stomach, not for digestion, but for quite the opposite. So, excuse me, I got saliva in my throat there. So, when you get a vasovagal response, a lot of stimulation from the vagus nerve doing this, it will cause you to have a slowed heart rate, cause you to sweat, can cause you to pass out. It also can have effects on the digestive tract. It can be stimulated by GI illnesses that are associated with diarrhea, although it can actually cause diarrhea too. It will cause you to try to purge from both ends in extreme situations. A lot of times it causes people to feel lightheaded, may even cause them to pass out. And you might wonder, well, what turns on this vasovagal response? It can be a response to toxins. And when I say toxins, this literally is toxins from a bacteria in the GI tract, like food poisoning. That can stimulate it. You can also get a vasovagal response to a fright or something very anxiety-provoking that you run into. So these are just a few things. You can actually create it manually. Doctors will do this on purpose sometimes by pressing in on the carotid bodies roughly in this area. Push on it or massage it, you can actually cause a vagus nerve discharge that will slow someone's heart rate down. And we do that clinically in certain situations, certain types of runaway heart rhythm disturbances where you want to slow the heart. That will actually be done on purpose. Another way to create it that we'll use is putting ice in someone's face or dipping someone's face into a bucket of ice water. That technique is sometimes done on infants who have heart rhythm disturbances to have their heart rhythm return to a normal rate, something under 100 beats per minute, because it's very effective and it's done without having to put an IV in them, and it can do something without having to use drugs that have other dangerous side effects. Now, it can actually make a heart stop temporarily, but I do not know of somebody getting a vagal response that caused permanent stopping of the heart or death, but it can slow it down terribly so that you have very extended times between heartbeats, and usually it picks back up spontaneously and comes back to normal rate. So I'm sorry I'm ignoring a lot of the comments. It's because I wanted to finish a good discussion on what I thought was an excellent topic, the vagus nerve or the vasovagal reflex. The body does do it on its own at times, but usually there's something that triggered it. May not be easy to put your finger on it, but something preceded it, and usually by not very far, like just seconds. Why does the body do this? Some parts of it make sense. For example, if something really needs attention and it's much more important than what you're digesting, like if you need to get away from something that's dangerous, purging out food or digested material from both ends helps you to lighten up what's going on and concentrate your resources on getting blood flow to muscles instead of to digestion. So that part of it sort of makes some sense. As far as a response to a fright, or the part where it makes a person pass out, it seems to be more of an overstimulation of what it should be doing. Food poisoning can make it happen, yes. Somebody eats food poisoning, they get sweaty, they throw up, they may even have diarrhea, they get all clammy, lightheaded. That can be a response to a food poisoning toxin. You betcha. Okay, so were any of those things that were going by while I was talking other topics? Friday Night Rock joins us. Thank you for joining us. Split S1, S2 heart rhythm, but no known symptoms. Reason for concern. Split S1, S2. So I believe S1 and S2, a split, well, okay. You have two heart sounds. One is with the closing of the valves on the right side of the heart, and the other one's with the closing of the valves on the left side of the heart. S1 and S2 are those two separate sounds you hear with a stethoscope when you hear the lub-dub sound, S1 and S2. Split just means you can hear separately the two valves, and it can be totally normal. There are certain heart conditions, though, that will accentuate that space and make it more obvious that there's a splitting of it. So then instead of hearing lub-dub, you'll hear lub-dub-dub or lub-lub-dub, depending on which one is split. And of course, that'd be usually worked up by a cardiologist, and an echocardiogram where they use an ultrasound to look at the heart to see why there's this difference going on. Also an EKG that would show you problems with the electrical conduction in the heart system. I say electrical conduction because it's actually like a little wiring system inside the heart that coordinates the beats. Yours is lub-dub-dub, or I'm sorry, lub-lub-dub. So that'd be the split S1. Now you said S1 and S2. That would be four separate sounds if you had split S1 and S2, but if it was just a split S1, it'd be lub-lub-dub. And that would be because of the give me a second here, the tricuspid and the pulmonic valve beating separately. Is cracking your knuckles bad for you? If you do it enough around me, behind me, during a meeting or at church, it will be bad for you. Because I find it annoying. No, I don't really do anything to people who crack their knuckles. I just want to. But that's about it. Just what other people would do to you if you get on their nerves enough, cracking your knuckles. But as far as your joints, I don't know that it's actually hurting them. Does it cause arthritis like people say? No, that's not the cause of arthritis. Now, as far as this perceived problem of the cracking of the knuckles making you have to do it more often, that's also I think more of a perception of people who do it because they need to do it, or they feel the locking up that they need to just kind of overcome to make the joint feel like it moves loosely. I don't know of any evidence that it was actually the cracking in the first place that caused it. Cracking your back, it bugs me when I see people do that, but I don't have any objective data to look at that says it is a problem. Don't have it at all. As far as the cracking, like you hear from chiropractors, their manipulation of the lower back and low back pain is very effective in a lot of cases at providing relief from pain. Now, the idea of nitrogen bubbles popping, that's one idea. Another one is that it's a tendon getting stuck on a prominence of the bone and kind of flipping over it or slipping over it. Sometimes I wake up in lots of pain. All I need to crack my back. Yeah, and so I can't help wondering, those people who are out there who don't have any problem with their backs and then aren't cracking it, where is the difference? Is it that the problem came first and they found the cracking helps it? Or is it they cracked their back experimentally or just out of trying something out or habit and then they needed it? I don't know. I should probably look at Clinical Key or look up the literature and find an answer to that for you guys, because I do not know. So you guys have good topics to talk about here. Okay, so for you, it was bugging you. You cracked it. It feels better. I would not tell you to stop doing it out of concern that's going to make it hurt less, because I just don't have any evidence that that's the case. So keep doing what you're doing. Dip in the bed of your toe. That would not work. That sounds uncomfortable. You may want to firm up that mattress there. Actually, I heard about this store. I actually know the owner of it. I think it's in Berkeley, California. They sell mattresses for tens of thousands of dollars. Crazy. Immunology, fighting against cancer at present. We're working on it. That's still cutting edge stuff. And when they do come up with treatments, we're talking really, really pricey. I mean, like in terms of $100,000 a year per patient. Now, thankfully, those type of treatments are usually 6 to 12 months rather than longer, but wow, for right now, this is expensive stuff when the drug companies come out with it. And of course, they justify it by saying, well, for every drug that worked, we had to, actually run through 5 or 6 in the early stages. That costs a lot of money. Stem cell research. I have no problem with the research itself. I do have concerns about the source of the cell lines that are being used, but nowadays they can get excellent cell lines from all sorts of places without having to harvest human embryos for that purpose. So the old days of that being a big area of concern is not quite as bad as it used to be. Can a testicle cyst can be removed without removing the testicle? Testicle cyst. I've never seen an actual cyst on the testicle itself. Plenty of cysts inside the scrotum. Lots of hydroceles or spermatoceles. And these occur either just in something that was called the tunica vaginalis, or a membrane layer that's present in development, both in men and women, thus the name tunica vaginalis. Plays a slightly different role in women because they don't have a scrotum. But it can fill up with fluid, and it's usually not a problem. Can cause pain and need to be removed because of that. And then the spermatoceles are in the vas deferens, I believe. And I don't know if people haven't had those removed. That is okay. You can always reconnect. Okay, vagus nerve. I like the way you spelled it. Las Vegas nerve. Thing why I need to go to the bathroom every time I'm in a bookstore. Okay, the reason you made me speechless there was because of the having to go to the bathroom at a bookstore, which makes me think you're one of Larry's friends if you're bringing this up, because that's a Larry Finney thing. Larry being the co-host of Medically Speaking Radio, who speaks to me about this effect that bookstores have on him, and apparently it does you, or you're just Larry trying to. Is that you, Larry? Did you come up with a fake Periscope name and you're doing this to me? If you do, I got you. So let's talk about it. Yes, having to go to the bathroom in the bookstores. I don't think it's the vagus nerve doing it. You're not Larry. Tothmo. Okay. Because that's a Larry thing. No, it's not the vagus nerve, nor is it the gastrocolic reflex. But I can talk about the gastrocolic reflex. Gastrocolic reflex is when the stomach is distended, there is stimulation both of nerves from the distension, but also some hormonal stimulation from the contents of the food that's being absorbed, and stimulates the colon at the other end to have some reflex motor activity to evacuate, to make room for what's coming. So your family should do a scope. Oh, Angela Hackett has joined us. Everybody, please, everybody, welcome Angela Hackett to Ask Dr. Vaughan and ask her how the weather is in Nebraska. So you asked about a fam scope and having the family on. Angela's probably as close as we're going to get. So everybody, welcome Angela. And give lots of hearts for Angela joining us. Show her what hearts are in case this is her first Periscope. All right, there we go. So, Angela, you see the hearts there? And you see people welcoming you? So the way they do hearts is they tap on the screen, just tap right on the picture of me, and it makes these hearts come up down in the corner here. It's their way of showing that they, well, welcoming you to Periscope, but also showing that they like whatever they're watching on Periscope. And apparently they like that you joined us. Yes, she is a family member. Okay, I was on Indocin for misdiagnosis of gout, had a hiatal hernia attack. Ever heard of? I have never heard of somebody mistaking a hiatal hernia for gout. Never, ever have. And Angela joined us again. Wow, what a lucky Periscope. We get Angela twice in one Periscope. I wonder what part offended her, so she turned us off the first time. No, I'm sure it was just a connection issue, as it usually is. Look at all those hearts. Have been working a lot with gout. Have been working a lot with the question of, is it gout or is it pseudo-gout, which is very similar, clinically very similar. The only difference you can find is actually on getting crystals from the joint involved, which, since sometimes it's joints and fingers or toes, and those are really tight little spaces to get a needle into, and there's not a whole lot of joint fluid from which to draw, you may not want to have a definitive diagnosis. You may just want to treat it with anti-inflammatory medicines and assume that it's gout and make the dietary changes recommended for gout, which is filled with both with things to avoid and with things to have. Things to have like cherries or cherry juice. Some people will use that. Indocin caused the hiatal hernia attack, high BP and high pulse, no gout. Indocin causing those things. More often, the Indocin will cause blood pressure medicine to not be effective rather than actually raising blood pressure. And it would help with the pain of the toenail too, by the way, being a strong anti-inflammatory. But it can cause problems with erosion of lining of the stomach, or actually can even cause ulcers, just like any anti-inflammatory medicine, including aspirin or the non-steroidal anti-inflammatories. Yeah, if you're on blood pressure medicines, it wasn't so much that it raised the blood pressure as that was the end result of it causing the blood pressure medicines to not be effective. It's a medication interaction. Twilight Bloom 71, thanks for joining us. We were just talking about gout in a person with a hiatal hernia on blood pressure medicine. So that can cause problems. Back to the pseudo-gout, you can tell the difference by looking at the fluid under a microscope and looking at crystals that are in it. Oh, I do the same thing. I put people on Indocin or on blood pressure medicines also. And it can cause problems with the stomach. It's just a risk of a medicine. Unfortunately, you had the bad effects of it. I can tell you on the other side are all the 9 out of 10 people who had resolution of their pain and were able to stop the Indocin. So people learned how to treat toenails at home. Yeah. Don't cut them. Let them grow out. And if it can't grow out because it's been cut too short and there's just no getting around it, sometimes you have to have that edge of the nail removed all the way down to the, or nearly all the way down to the nail bed. That's an unpleasant procedure. Fun to do, not fun for the patients. Hard to get a real good anesthetic set up on a toe. because it requires putting a shot in to get the nerve. And you can numb up the skin with some topical creams, but to get a real good block on it, it takes some shots. Mario 87 Dodgers, thanks for joining us. We're glad to have you on Ask Dr. Vaughan. And it's Bird, thanks for joining us. Cheers from California, and cheers from California, Northern California, here in Auburn. And let me look here to see if Angela is still joining us. I guess she got enough. She must have either taken off or I can't see all the people who are a part of it. Had part of the nail removed down to the bed, never grew back. It's hard to make them not grow back. There are medicines that will use cytotoxic, meaning cell-killing agents, to purposely try to kill off the cells in the matrix of the nail bed so it won't grow back when people have recurrent ingrown toenail. But it only works less than half the time. So I've actually taken to not even trying to kill off the nail bed myself, leaving it to the podiatrists who have better tools than I do, like lasers, to kill off that part of the nail matrix for those people who have recalcitrant or recurrent ingrown toenails. Awful thing to have. So, here we go. I work with GI docs, CMA, wondering what we can do about hemorrhoids. I've heard surgery. Let's not jump to surgical solutions when we might be able to do something else, like maybe decrease the things that contribute to it. So, some things to consider are increasing roughage in the diet, fiber, increasing water consumption. These are things that will help bowel movements to go easier and decrease pressure inside of the colorectal system. Other things that can be done are topical treatments like just plain old preparation H. So the first thing is to get the cause taken care of, and that's the pressure inside the GI tract. Yes, lentils, that's funny. If you can stand to eat lentils. Metamucil is often used. Okay, and then if that's not successful, I will say there's a bit of controversy with this, but I've had success with it, and that is to go looking inside with an anoscope to see if there's internal hemorrhoids in the veins leaving the anus inside of the rectum, and then you can ligate those with a band, which is a cool procedure to do. It's a tiny rubber band, goes around it, and within 2 days you have this little bloody nub that comes out with the stool, and then you're done. Of course, until then, because that's inside the rectal vault, it feels like you have to go because there's something in there. Problem is it's attached, so you can try to go, but it's not coming out. Of course, that has to be done carefully. Not every case of internal hemorrhoid I come across lends itself to that. We go in and we test with these little forceps. And if the patient says, that's uncomfortable, I can feel that pinch, I can't do it. I'll send them on to a surgeon. And I love reading the surgeon notes when I do this because they say they go in and test it and the patient feels it and says, you can't do that. Well, that's what I told you. So then they schedule to do it with anesthesia. And they'll actually surgically go in with a scope and with the person sedated and numbed up, go ahead and take that out. And usually that helps with the production of the hemorrhoids. Now, I have read some suggestion in the literature that actually doesn't make a difference in future hemorrhoids coming out. But clinically, my experience is that patients get the problem taken care of and the hemorrhoids don't come back. Now, there's something called thrombosed hemorrhoids. Hemorrhoids, of course, are these dilated blood vessels right on the anal verge or just next to it. And they can have clotted blood, and that can be really painful. It will eventually pass. I mean, it doesn't pass, but it goes away. Just give it enough time. It can be very uncomfortable. And then those people who just absolutely cannot wait for it to go and use the preparation H with cortisone or Anusol is the same thing. We can cut them open, get the clot out, and the stuff in it looks just like that periscope we did when we were cleaning out the guy's hematoma on his knee, or just below the knee. Some of you can look at that on AskDrVaughan.com if you want to see it. Yes, you're welcome. So we get all the clots out. And it hurts to get shots there to numb it up. But some people say that's better than going through the next couple days with the pain of a thrombosed hemorrhoid or clotted hemorrhoid. So we'll get all the blood out, and then we'll leave it open, and it continues to drain blood. It's kind of a bit of a a mess because you keep having this blood leaking out until it finally heals and closes. But you have to leave it open, because if you sew it closed, all the blood reaccumulates and the clot forms again, and the patient will come back for it to be done a second time. That only happened once, very early in my career. No more. So unpleasant. I will do it for those patients who absolutely say they want to have it done. Now, somebody asked about a cure for common cold. I do not know of one. It would take an incredible antiviral to do it, because cold viruses, first of all, there's about 100 of them, and they're always changing. And again, that's how there are about 100 of them. So you're continually through life building up your repertoire of antibodies to all these different cold viruses. Cold viruses being of several families. You've got rhinovirus, crinivirus, parainfluenza virus, and these are just ones I can think of off my top of my head. There's about 10 of them that are very common, and they have all different variants of them. Just like you hear about the different strains of flu virus that go around, we put in the flu shot. Well, imagine instead of just influenza, you've got all these 10 different types having all their different subtypes, and that is what colds are. And so they can be different from time to time. You've got your ones that kind of have a liking for the upper respiratory tract, the head cold, the ones that kind of have a liking for the bronchioles, the chest cold, or so-called bronchitis. And don't be confused by bronchitis sounding like something different than a chest cold and needing antibiotics. That's not the case. And then as far as bacterial bronchitis versus viral bronchitis, really, unless the bacteria got so far down that they're in a state of pneumonia, you will get over it. Unless you have chronic obstructive pulmonary disease or some kind of other chronic lung disease or immune suppression. If you're a healthy young adult, healthy adolescents, you'll get over it. The things to get checked for are if you have shortness of breath, coughing up blood, chest pain, and I tell people with a fever, get checked. And then if you have what is diagnosed as a viral infection or even a bacterial bronchitis that will go away eventually, the color of the sputum. The color of the sputum is just simply the presence of bacteria in the sputum. You can change the color by taking antibiotics. It doesn't necessarily make you get over the underlying problem any quicker. You do get over these things. But if there is a change, even if you've already been checked by the doctor, if there's a change, increasing shortness of breath, wheezing that you don't usually have, chest pain, blood when you cough, increased fever or harder to treat fever, get checked again. These things change. These things do progress. And you can get bacterial superinfection or secondary infection on top of the viral infection, or the bacterial bronchitis can turn into a bacterial pneumonia by going down lower. A lot of people want to have the antibiotics thinking this will make me better when it doesn't, or this will keep me from getting worse, and actually that too is intuitively what would happen, but not what happens clinically or when we actually do studies on it. Evening, we'll catch you later. The problem is you do have to get rechecked if the symptoms change, or if your doctor knows you and knows your health, and you have a very good relationship with your doctor where you have this knowing of each other, and you can call them up on the phone and they can be comfortable with the fact that you don't need to get reevaluated because of your health state. They may choose to go ahead and call in the antibiotics. And that just goes to, a lot of this is relationship. You know, my patients who have things going on, and so I see them more often because they have health issues that need to be addressed, I will go ahead and do things over the phone for them because I know them, and they do come in for frequent checkups and they don't get lost to follow-up. Things for them that I won't do to a person who, yeah, maybe I recognize your name, but oh man, I don't know your health situation that well, especially over the phone. You know, like if I'm not where I can easily read the chart. So relationship, like everything else, it's all about relationship. So you guys, this has been an awesome session. I appreciate all you coming. Angela, if you're still around, thank you for checking in and seeing what this is all about. Certainly hope to see you in the future. And those of you who have friends who like medical topics, swipe right and share. Those of you who don't already follow, swipe right and follow. When I say swipe right, that means put your finger on the screen and move it to the right, and you'll see the little place to follow me. It's a little icon, looks like a person or a little place that says to share. So yes, you're welcome, Tothmo. Enjoyed talking with you about your medical history, and we will do this again probably next week, but sometimes I surprise you over the weekend. And if you want to be a part of it, over the weekend, I forgot, 10 o'clock Pacific time, we do Medically Speaking Radio on Periscope, on this very Periscope, in addition to doing it live over medicallyspeakingradio.com. Yes, thank you, Empire City Ray. Miss TV Addict, also, I want you to know this too, that your friends who don't have Periscope can catch the show tomorrow at medicallyspeakingradio.com at 10 o'clock, and it live streams over the internet. And I think we'll still keep intact the ability to call in by Skype with your voice, but we also do look at the comments on Periscope and interact with our Periscope audience. So until 10 o'clock Pacific time tomorrow morning, this is Dr. Vaughan telling you to stay in good health.